Hello, I am Richard Bogan, and on behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode one of the four-part CMEOCast series, Fine-Tuning Diagnosis and Management of EDS in Patients with Narcolepsy and OSA. Today's episode will address I Shouldn't Be This Sleepy, a look into EDS. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Again, I am Richard Bogan, president of Bogan Sleep Consultants, LLC, medical officer of SleepMed Incorporated, and director of SleepMed of South Carolina. I'm also the associate clinical professor at the University of South Carolina School of Medicine in Columbia, South Carolina, and associate clinical professor at the Medical University of South Carolina in Charleston, South Carolina. I'm very pleased to be joined today by Nancy Folveri Schaefer, professor of neurology at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University and director of the Cleveland Clinic Sleep Disorders Center in Cleveland, Ohio. Welcome, Nancy.
Thank you for inviting me.
Yeah, this is great. So we're going to talk about excessive daytime sleepiness, and to frame today's episode, let's start by reviewing our learning objective, which is to identify the burden of EDS on patient functioning and quality of life, highlighting the need for early detection and treatment initiation. We know it's amazing that patients are sleepy and they don't know how sleepy they are because sometimes they're tired and sometimes they're depressed or moody or irritable, or they can't think and they can't remember. And some of the patients that are the most sleepy are narcolepsy. So Nancy, let's begin with a look at what we know about the incidence of narcolepsy and how it relates to EDS.
Yeah, so EDS is the hallmark feature of narcolepsy, and up to 200,000 people in the United States have narcolepsy. Importantly, on average, about 5% of patients seen in the United States Sleep Disorders Center have a primary diagnosis of narcolepsy. And narcolepsy is the second most common cause of daytime sleepiness seen in U.S. Sleep Disorders Center after obstructive sleep apnea. So it's an important cause of excessive daytime sleepiness. Also, comorbid conditions are commonly present in people with narcolepsy, and that can really confound the diagnosis. So for example, 25% of people with narcolepsy also have obstructive sleep apnea, and having OSA alone can delay the recognition of narcolepsy.
Exactly. Well, you mentioned that narcolepsy can occur with other primary sleep disorders, and I think that's one reason sometimes we have trouble making the diagnosis. Remarkable illness that is unique and gives us a window into how the brain controls sleep and wake, and these individuals are impaired, but they oftentimes have other comorbidities.
Right. So a host of medical, psychiatric comorbidities, and as we already suggested, sleep disorder comorbidities exist in this population. So there was a retrospective analysis using health claims database data that involved over 9,000 narcolepsy patients and over 46,000 controls. And this study identified an excessive prevalence of many psychiatric and medical disorders. Top of the list, besides comorbid sleep disorders, are mood disorders, depression, anxiety, headache disorders, as well as diabetes and obesity. And also important to recognize is that the treatments of some of these medical and psychiatric disorders can either exacerbate daytime sleepiness in people with narcolepsy or can potentially mask important features of the presentation of narcolepsy. So as one example, using antidepressants for treatment of mood disorders in this population can theoretically mask the presence of cataplexy, which can delay the diagnosis of narcolepsy.
Exactly. You know, I'm impressed because many people don't realize the disrupted nocturnal sleep. And when you talk to a bed partner of a patient who sleeps with narcolepsy patient, they'll tell you they're busy at night, and oftentimes they have dream enactment or vivid dreams and other things that are going on, and oftentimes they get diagnosed even as having insomnia. And as you said, a significant number of these individuals, maybe as high as 35%, have comorbid mood disturbance and other things that are going on.
That's right. And so REM sleep behavior disorder, dream enacting behaviors, periodic limb movements, kicking at night, even restless legs, and insomnia presentation can all confuse the presentation of narcolepsy. And this has been demonstrated that 60% of people with narcolepsy are misdiagnosed with some other common disorders like insomnia and depression, even after seeing multiple providers. And it really speaks to the need for more universal education of frontline providers who treat patients with common disorders like insomnia and depression.
Yeah, I would agree. You know, I had a school teacher one time who came to me, wanted a sleeping pill because she was waking up frequently at night. She said she was busy all night because she was dreaming all night. And she would take a nap when the kids were dreaming, excuse
Yeah.
me, when the kids were reading, she would take a nap in class. But people with insomnia can't nap, but she thought she had insomnia. So this is really very, very common. Well, we talk about the sleepiness and narcolepsy, but what do we know about the impact of excessive sleepiness in individuals with obstructive sleep apnea?
Yeah, so excessive daytime sleepiness is among the most common daytime symptoms reported by obstructive sleep apnea patients also. And so a multi-center trial that included 128 patients with moderate to severe OSA who were treated with CPAP for 3 months and had baseline and follow-up assessments really illustrates that a good percentage of people with obstructive sleep apnea fully treated with CPAP therapy continue to have daytime symptoms, including excessive daytime sleepiness. This particular study used the Epworth Sleepiness Scale, as well as the FOSS-Q, and derived an MSLT, which is an objective measure of daytime sleepiness, and found that over half of the population, despite using CPAP for at least 6 hours, continue to be abnormal on the MSLT, which is an objective measure of daytime sleepiness. So this is important not only for the quality of life of people with obstructive sleep apnea, but also could be an important cue that maybe you're dealing with a patient with obstructive sleep apnea who also has a hypersomnia disorder, potentially even narcolepsy.
Yeah, well said. You know, when patients come to us, they come to us because they don't want to die, because from the sleep apnea, but they also don't feel good. And the majority of them are excessively sleepy. It's the most common, as you said, in the clinic. It's the most common presentation for sleepiness is obstructive apnea. But it is impressive that some of these individuals, despite our best efforts, are still sleepy. And we need to pay attention to that, not just look at their AHI on their download, but ask them, are they sleepy? And many times the patients don't know how sleepy they are, to be honest with you. They've been that way for a long period of time. And sleepiness can present in many different ways. Can you expand on that?
Yes, so I think there's a large percentage of patients who probably underestimate daytime sleepiness, particularly because they've known themselves to be sleepy for so long. I think this is common in narcolepsy because sleepiness starts in narcolepsy very often in even the first decade of life, often the second decade of life. But sleepiness can present in so many shapes and forms and is really different in young patients versus old patients. So for example, in children, sleepiness often presents sort of like an attention deficit hyperactivity disorder with hyperactivity, distractibility, irritability, and mood complaints can also present as sleepiness in adults, but I think that's most impressive in the pediatric population. But also, it's important to note that across all ages, people with sleepiness have a lower performance academically. They struggle to perform optimally at work. They have a high incidence of accidents and injuries, including motor vehicle accidents.
Yeah, I mean, to be sleepy, I say, all sleepy people are tired, but not all tired people are sleepy. So you have to sort of separate those. But I've had a patient, for example, with narcolepsy, have automatic activity driving down the road and miss the exit, and 4 miles later realize it. And what they asked about was their memory. So the effect on executive function, memory, mood, all those things are very, very important. And given this high incidence of difficulty in diagnosis, both in obstructive sleep apnea and narcolepsy, qualifying are they sleepy and quantifying how they are sleepy. Do you want to comment on some of the patient-reported outcome measures and methods by which we can measure sleepiness?
Yeah, so beyond asking the patient, and if the situation permits, asking caregivers and parents and loved ones, I think it's very useful as well. Beyond those subjective measures, it's very useful to use validated subjective measures that have been proven over time and studied for their validity in both narcolepsy and obstructive sleep apnea. So the Epworth Sleepiness Scale is the main one. It's an instrument that's used worldwide for ascertaining one's likelihood of falling asleep during the daytime. And it's a simple scale measuring one's chance of dozing in 8 different everyday situations. And the Epworth can also be used not only as a diagnostic supplement, but also to track performance over time and to track response to therapy over time. Another commonly used instrument is the FOSQ. So this is a measure of how sleepiness affects daytime functioning, and it includes 5 different domains, including productivity, activity, vigilance, social outcomes, and intimate relationships. But as you allude to, it's important to recognize that subjective measures rely on the person's own ability to report this, and not everybody really reports this well. Some people describe themselves as sleepy, as tired, even though they're sleepy, or sleepy when they're tired, or cognitively impaired with a poor memory, or even distractibility, as if they have an attention disorder.
Sure. Yeah. And, I found the FOSQ very helpful. We do that every time the patient comes in. We do an Epworth score and a FOSQ. We actually do an insomnia index as well, which is kind of interesting. But the FOSQ sort of gives you some insights into the functionality, the driving performance, for example, or thinking and memory, executive function. So it gives you a functional assessment of how the sleepiness is affecting someone. But we, in thinking about the scores, I think there's some benefit. My Epworth score is about a 5, I think. No, I don't know what yours is, but tell us about what the actual scores are.
Yeah, mine is probably a 5 or a 6, I'd say. The ESS is very easy to administer. The choices range from 0 to 3. So over 8 items, the total score can be as high as 24. So from 0 to 24. And we know, based on a large body of literature, that scores on the Epworth Sleepiness Scale of 10 and higher are considered abnormal, therefore indicative of some degree of daytime sleepiness, and scores of 16 and higher are indicative of more significant daytime sleepiness. The MSLT has been correlated with the Epworth, and so we know that there is somewhat of a linear relationship, or a reverse linear relationship, between the Epworth and the MSLT, meaning that higher scores on the Epworth indicate more sleepiness, which is represented by a shorter mean sleep latency. Also, by the way, we know that different populations present differently on the Epworth. And so, for example, sleep apnea populations tend to score themselves lower on the Epworth than narcolepsy patients. And one study using the European Narcolepsy Network data identified that OSA patients had a mean Epworth of 9, whereas narcolepsy patients had a mean Epworth of 17. So I think the Epworth is very useful. We do it as well in all patients. We do the Insomnia Severity Index as well, and the FOSQ. And I think just looking at those 3 instruments supplemented with the clinical history can really go very far in identifying the person who has a CNS hypersomnia disorder like narcolepsy.
Yeah, they sort of guide you, and again, I call it qualify and quantify. So are you sleepy? How sleepy are you? And then, as you say, you can begin to dig down into terms of the functionality, in terms of how it's impairing someone. So in everyday practice, what would you consider an ideal approach to detect excessive sleepiness in narcolepsy and OSA patients to determine if treatment is actually indicated?
Well, all people should be queried about their sleep, and that includes daytime sleepiness as well as how much sleep we get, because we live in a society that's sleep deprived. So it's also important to recognize insufficient sleep, right, in the differentiation of hypersomnia disorders. Again, I really like to get observers from family members if there's observations to be had. And then I move on to the subjective assessments that we discussed, often the Epworth Sleepiness Scale, the FOSQ, and then use that information to decide what's the next right step. If the clinical suspicion of narcolepsy is high, the next right step, as long as the patient is not chronically sleep deprived, would be to proceed with laboratory testing. And that includes a polysomnogram followed by an MSLT. If obstructive sleep apnea is highly suspected, I would proceed with either polysomnography or perhaps a home sleep apnea test if the patient doesn't have comorbid conditions. And if I hear something in the history that really raises concern for either a circadian rhythm disorder or insufficient sleep, I may ask the patient to maintain a sleep log. This is done on a piece of paper, or it can be done in a journal, or it can be done on an app on your iPhone, and return to the clinic after a few weeks before proceeding with sleep testing. It's important really to tailor the sleep test, right, to the individual question. And so I think it's important to make sure you have as most clinical information as you can get before you choose to proceed with laboratory testing. And then of course, after testing, it's important to really assess again for daytime sleepiness and put it all in context. So in the setting of obstructive sleep apnea, people who are treated with CPAP, we should be ascertaining sleepiness across the patient's, treatment period and long term. We check upward sleepiness scales in every patient coming to the sleep center every time. And sometimes people respond to CPAP initially with an improvement in daytime sleepiness, but sleepiness reemerges. And a subset of those patients could have narcolepsy, perhaps, or they may be appropriate for initiating some form of pharmacotherapy. And then, of course, on the narcolepsy side, I really spend a lot of time really thinking about the results of the PSG and thinking about the results of the MSLT, making sure those tests are valid, particularly if the results don't quite match the clinical story. And then, of course, after the testing confirms narcolepsy or some other CNS hypersomnia, it's important not only to discuss initiating therapy, but also discuss the expectations of therapy, because sometimes these therapies take time to really take effect. And in the end of the day, many patients with narcolepsy, despite optimal therapy, will continue to have daytime sleepiness and other struggles related to academic and work performance.
Yeah, I always tell my referral base, if you have someone who's tired or can't think, remember, or has mood disturbance, you need to determine if they're sleepy or not, because if they're sleepy, we can find a reason and we can help that, and that will help a lot of different things. So again, it's we know what state is the brain in and what are the biological processes, and the sleep study allows us to see that if there's any pathology. And the nap studies in the daytime. What does your brain do in the daytime when all these neurotransmitters are trying to keep you awake and you remove sensory input? What does your brain do? And the nap studies oftentimes give us a clue as to what's going on. I wish we had time to talk more about pathophysiology and why these people are sleepy. That'll be another session. But Nancy, thank you for providing us with a great overview of the burden of excessive daytime sleepiness and why there's a need for early detection and treatment initiation. Now let's close with our SMART goals. That is specific, measurable, attainable, relevant, and timely goals. What should healthcare practitioners listening today take away from this podcast? They should recognize the burden imposed by EDS in pediatric and adults with obstructive sleep apnea. Use evidence-based tools to improve your detection of EDS in patients with OSA or narcolepsy, and identify patients in whom it is appropriate to initiate treatment for EDS. Now, to receive CME CE credit, click on the link identified here to complete the post-test and evaluation online. Thank you very much for joining us today, and please visit Sleep Disorders Hub at www.cmeoutfitters.com Sleep Disorders-Hub for additional educational activities, resources, and tools to improve the care of patients with excessive daytime sleepiness. Thank you for joining us today for episode 1 of our 4-part CMEOCast series. To view additional episodes on matching treatment choice to the pathophysiology of sleep, differentiators when choosing novel treatment options for EDS, and diagnosing and treating pediatric narcolepsy with cataplexy, please visit CMEOutfitters.com. Thank you very much.